A very good afternoon to all of you. At the outset, I would like to thank MAPICON organizing team to give me this opportunity to speak on this platform. First of all, why this topic was chosen? Because PSA is one of the most common self-prescribed lab tests, especially because of these labs. They are proposing packages. In that, PSA is part and parcel, be it a 30-year male, be it a 80-year male. The package is same. That's why one is the reason. Another, but also it is one of the most misinterpreted tests. That's why we thought that this test needs more awareness about indications and interpretation of this common lab test. Now, I will start my presentation with few index cases. This is case 1. 70-year-old male, asymptomatic, very healthy lifestyle. He got PSA screening done because he heard on social media about PSA. So his serum PSA came out to be 6.5 nanograms per ml. And in the lab, cutoff value is 4 nanogram per ml. Now he and his family is worried. Now what to do next? Either transrectal ultrasound, prostatic biopsy, MRI prostate, or a PSMA PET scan. Now another index case. This is a 84-year-old male who was being evaluated for abdominal pain. He gets serum PSA as a part of, again, investigational package. PSA is 24 nanograms per ml. What to do? This is one of the prescription I got on my WhatsApp from my uncle. 78-year male, everything is fine, just got PSA during COVID phase. PSA was 8.1. I will tell you what we did in next. Otherwise, his symptoms were, urinary symptoms were well on alpha blockers. Now what to do in this case? Next. Now this is a very interesting case. A 52-year male who had acute urinary retention with acute prostatitis got serum PSA done. PSA came out to be 14 nanograms. Again, what to do? This is the WhatsApp communication with this patient. You can see in August 2022, they sent me the reports and I asked him why this PSA was done. See what he has written. Somebody told me, not doctor. Now next, see, I told him that get PSA after 3 months. He said, sir, any precautions for PSA? He's still worried, what will happen? Then for 3 years, he was all right. In this July again, 2025, he got acute prostatitis and again he got PSA done. It is 19. I will tell you what happened with this case. This is another interesting case. A 36-year-old male who had recently, his grandfather died of certain cardiac disease but was having prostate cancer. So out of fear, he got PSA done. His PSA is 4.5. 36-year male. What to do now? Now, briefly, I will tell you what is PSA. PSA is a glycoprotein that is produced by normal prostatic intraepithelial cells, and it is widely used in prostate cancer detection and monitoring. Although its role in screening it's very controversial. Guidelines differ with regard to use of PSA in screening for prostate cancer. Now I will come to various facts and myths associated with PSA. PSA, as the name says, it is a prostate specific antigen, not prostate cancer specific. So first myth is PSA is specific only to prostate cancer. The answer fact is it is prostate specific, not cancer specific. So it also increases in benign conditions like benign prostatic hyperplasia, prostatitis, retention of urine, any transurethral procedures like catheterization or PRP or prostatic biopsy. Another myth is if one is having a normal PSA, does it rule out prostate cancer? Again, fact is no. Even patients of prostate cancer could have normal PSA, like neuroendocrine tumors of prostate or highly undifferentiated prostate cancers could have normal PSA levels. So there is no direct correlation between the serum PSA or prostate cancer. Another myth is screening PSA testing is suitable for all men. Again, fact is routine PSA screening is not universally recommended for all the patients. Rather, persons. Decision to screen a person for prostate cancer using PSA should be individualized based on age, family history of prostate cancer, his race, overall health and life expectancy of the person. Another myth is if universal PSA screening can prevent all prostate cancer related deaths. No, fact is one is ERSPC trial that says that even if go for universal PSA screening, it will reduce the mortality due to prostate cancer by only 20%. Rather, it leads to overdiagnosis, overtreatment, and apart from that, anxiety in patient and family. Another myth is PSA level is the only test needed to diagnose prostate cancer. Answer is big no. It is just a screening tool. We need digital rectal examination, prostatic biopsy, imaging in the form of either MRI or PSA PET scan, and also additional parameters like PSA velocity and PSA density. Another myth is PSA level in an individual are always stable over time. Fact is no. PSA levels vary depending upon the prostatic condition like prostatic inflammation, physical activity of the person, and certain medications like we are prescribing finasteride, dutasteride to the patient, they also affects the level of PSA in a particular person or patient. That's why rather than a single report, it is a trend of PSA that matters, not a single report. Another myth is high PSA level means more aggressive disease. Fact is no. Even very high PSA level can be seen in advanced disease, but that doesn't mean it is aggressive disease. Even low grade tumors could have high PSA if disease is bulky at the presentation. Another myth is a single cutoff, as we see in lab reports, cutoff value written is 4 nanograms per ml for all the age groups, but this is not the case. Factually, in the 4th decade of life, cutoff value is 2.5 nanograms per ml, and in the 7th decade, it is 6.5 nanograms per ml cutoff value. Now, if another myth is PSA is useless once one is diagnosed with cancer. No, it is essential tool for following the patient following treatment of prostate cancer, for monitoring the progress, for monitoring the response to treatment, and to diagnose the biochemical recurrence following treatment. Another myth, if PSA is obsolete, no, still it is a important biomarker along with adjuncts like newer modalities, free and total PSA ratio, prostatic health index, 4K score, and PCA3 marker. Now we come to the indications and contraindications of PSA screening. When to do PSA testing? So in men aged between 50 to 70 years, PSA can be offered after informing the person about risks and benefits of screening. Also, as sir has told that if PSA level is less than 1.1 nanogram per ml at the beginning, it should be done every 2 years, not 3 monthly. And if PSA is more than 1 nanogram per ml, it should be done annually, not 3 monthly or 6 monthly. This cutoff value of PSA screening can be decreased to 45 years of age of a person if there is a family history of prostate cancer. Either one of the first degree relative had prostate cancer before the age of 65 years. Then screening can be started at the age of 45 years in a particular person. This age can further be decreased to 40 years of age if family history is very strong, like presence of BRCA1 or 2 mutations in family. Then screening in a person can be started at 40 years of age. This is the most common indication we are facing. Every patient of Lutz is getting PSA done, but here PSA may be considered but not recommended. for patients with lower urinary tract symptoms. Now next is when not to do PSA testing. Men less than 40 years of age should not be done. Between 40 to 50 years should be avoided until unless there is family history. After 70 or 70, some guidelines say 75 years, others say 70 years of age, or if life expectancy of the person is less than 10 to 15 years, it should be avoided. And also PSA testing should be avoided at least 6 weeks after prostatitis, prostatic biopsy, urinary catheterization and urinary tract infections. Now coming on to index cases again. As we saw in index case 1, patient was 70-year male, asymptomatic, healthy, PSA was 6.5, what to do? We have to look into his age, life expectancy, and we have to discuss with the patient, right, like for what are the possible risks and benefits, and what are the outcomes if he gets prostate cancer, what with or without treatment. Then we have to plan accordingly. In the index case 2, here age is 84 years, and at the outset there was no indication of PSA, it was not needed, but he has got it done. We have to discuss with the patient and family about the risks and benefits about the diagnosis and treatment to proceed further. Now third case, that was very interesting. In this case, he was having acute prostatitis with UTI, and earlier in 2022 it was 14. In between 3 years he was all right. Now in 2025 he had again a prostatitis and PSA was 19. In this case there was no indication. This was rather a true contraindication of the PSA. In this case we have to operate upon this patient. We did TRP because patient failed catheter-free trial twice, and we can see the biopsy report here. Here is the benign prostatic hyperplasia. We can see here. So in another case, this fourth index case, this was young 36-year-old male, family history of prostate cancer, but that was diagnosed after 65 years of age in his grandfather. So this is not a typical case. In this case also there was no role of screening PSA to be done in this case. Rather we can offer genetic testing to this guy rather than going for PSA. So clinical pearls are PSA must be interpreted in a clinical context of the index patient. Testing should be avoided during infections, catheterization and post-ejaculation and post-biopsy. PSA screening only as a shared decision making after knowing all the risks and benefits associated with it. And we should combine PSA with DRE with or without imaging to further diagnose the prostate cancer. So this presentation was based on the guidelines from NCCN, US PSTF, American Urology and European Urology Association guidelines. And take home message is PSA is a valuable but imperfect test. Myth, there are actually unrealistic expectations from the PSA, and decisions should be actually informed between the patient and physician before prescribing PSA, and goal should be individualized patient management. Thank you so much.